Hello everyone, this is Dr. Ola Adri. We're gonna proceed today to the next lecture of maxillary sinus pathology. Today we're gonna focus on oro-antral communication. Oro-antral communication is the invasion or intrusion into the maxillary sinus and establishment of direct communication with the oral cavity. That is called oro-antral communication or fistula. What is the difference between communication and fistula? We're gonna talk about later. Oro-antral communication is immediate communication between oral cavity and maxillary sinus through perforation of the sinus wall. And if this communication wasn't managed up to 3 days, epithelium will creep from the oral cavity and from the sinus wall and meet on the communication, forming an epithelial lining. That's called change of the oro-antral communication into oro-antral fistula. Here is, you can say the difference between the communication and fistula is the time factor and formation of an epithelial line fistula or fistulation. What is the complication of the oro-antral communication or fistula? There will be passage of food, smoke, fluid, bacteria from the oral cavity to the sinus, and from sinus through the ostium of sinus to the nasal cavity, which is distressing to the patient and embarrassing. The most important is the invasion of bacteria, fungi to the sinus, creating or leading to maxillary sinusitis. Here is also medical legal problem, maxillary bone violation or loss, which is significant for implant placement later on, or later rehabilitation and support for denture. Also, the surgeon repetition is affected. Oro-antral communication can be classified according to time factor, as we said. Immediate communication and proceeding of communication up to 3 days is a oro-antral communication. More than that is oro-antral fistula, delay, and patient coming delay after extraction of 1 week muscle. This is oro-antral fistula. According to the location, it could occur according to the cause palatally. On the palatal side is palatal fistula, buccal side buccal fistula, or even crestal on the alveolar crest. The communication may occur due to traumatic dental extraction, due to careless use of elevators, or excessive force during extraction, especially if there is loss of bone in the periapical region due to infection, or tumor from the oral cavity encroaching on the sinus, or tumor arising in the sinus encroaching on the oral cavity. Both will cause oro-antral communication, or infection in the maxillary bone and bone marrow encroaching on the sinus also. Caldolac operation, as we mentioned before, the buccal wall, if the flap necrosis or dehiscence occurred, there will be communication from the oral cavity to the sinus. This is buccal oro-antral or labial oro-antral communication of fistula. The site will be on the labial side. General trauma, not traumatic dental extraction, may also cause to whatever accident or fracture of maxilla may lead to the maxillary sinus communication with the oral cavity. Also, the dentagerous cysts encroaching on the sinus, maxillary cysts related to the upper wisdom. Also, we said tuberosity fracture, then to alveolar or periapical infection of molars, implant dislodgement, especially when there is insufficient bone or primary stability. Here you can see that traumatic dental extraction is the most common cause of oro-antral communication, especially for the teeth which are most related to the sinus, that we said before, upper 7, followed by 6 and 8, 5, 4, 3 by order. With the closest one is the mesiobuccal root of upper 7, average distance from the sinus floor 1.97 millimeters, and the farthest root is the buccal root of upper 4. Diagnosis of oro-antral communication mainly by signs and symptoms and assured by radiography. For immediate oro-antral communication, we're gonna see that antral floor is attached to the roots of apex of extracted teeth. Fracture of alveolar process or tuberosity, especially as traumatic dental extraction of upper 8. Abnormal deep socket following extraction or root disappeared after fracture of the root. Positive nasal blowing test or mirror test, where we place a dental mirror below the socket suspecting oro-antral communication. We're gonna ask the patient to pinch his nose and let him breathe forcefully into the nostrils while they are closed. We're gonna see bubbling of blood through the socket or communication, or fogging of the dental mirror. Sometimes when the communication is large enough, we're gonna see that there is change in speech tone or resonance of voice, and we assure the diagnosis by radiographical evidence of sinus involvement, as you're gonna see. For delayed or chronic Oro-antral communication means that changed into Oro-antral fistula, the patient usually come complaining of regurgitation of fluids from the mouth into the nose, or difficulty in holding intraoral pressure, so he cannot blow out his cheek, or difficulty in smoking, sucking through straw. There is also complaint of foul odor or foul unpleasant taste, or even virulent discharge if infection follow maxillary sinusitis. This pus will be extruded from the communication. Also, the patient may complain of history of intermittent pain or tenderness in the affected region. Sometimes, if the patient is partially edentulous, there will be a report of denture instability due to the air flow between the oral mucosa and denture. Diagnosis is mainly based on history. There is a history of traumatic dental extraction or trauma or infection. Clinically, there will be by inspection a communication or fistulous tract between the oral cavity and maxillary sinus, or we're gonna see a pus extruded from the sinus. Positive nasal blowing test, meaning that there is fogging in the mirror, or if negative nasal blowing test, don't explore the opening with dental probe or even suction tip. Also, don't attempt to irrigate the sinus to confirm diagnosis, especially if the sinus drainage is impaired due to pre-existed sinusitis. To check the diagnosis, always check radiograph for the continuity of the sinus floor or presence of entrapped foreign body such as remaining root or implant at the sinus floor. Here is interruption of the sinus floor or opening from the sinus floor evident on the radiograph, here at CT. It is abnormally widened socket following atraumatic dental extraction. Here is the nasal blowing test while patient pinching his nose, and if there is a communication, there will be flow of the air through the communication into the oral cavity. Probing and irrigation are strictly prohibited to assess or examine Oro-antral communication. Simply, it might transfer the oral bacteria or contaminated tooth or bone fragments into the sinus. It might cause mucosal tearing if it is intact and there is only a pinpoint bony communication, but still the mucosa is intact. It will cause mucosal tear. Also, if it's pinpoint, it may enlarge, probing may enlarge this communication and decrease the chance of spontaneous healing. And so, if we suspect an Oro-antral communication, we should first examine the extracted tooth for any attached bone fragments, especially for the teeth mostly approximating the sinus, or upper 8 for the attached part of tuberosity, followed by performing nasal blowing tests and determining the site of the defect by periapical or relevant radiograph. If the communication or disruption of the sinus floor less than 2 millimeters, no treatment is required and is gonna heal with spontaneous healing. As we know, prevention is better than treatment in any condition, so there are protective factors that expect whether communication may occur or not. We, as a routine, should perform a periapical X-ray before performing dental extraction, at least to assure the diagnosis or the cause of extraction. If the tooth is highly approximate to the sinus or upper molars, the roots protruding into the sinus, we should take care to perform atraumatic dental extraction. Also, hypercementosis, presence of hypercementosis on dental X-ray, or root fused into the maxillary bone or ankylosis, high risk to communication during extraction. Presence of periapical infection or marked periodontitis causing periapical infection. Long-standing large lesions encroaching on the sinus, or there is a previous history of Oro-antral communication. All those increase the risk of Oro-antral communication. So, based on the protective factors, to avoid dental dislodgement of tooth or even remaining root to the sinus, we should perform sufficient apical grip to avoid dislodgement into the sinus, and preoperative careful radiographic assessment for specially isolated teeth where condensing osteitis occur because of the increased load on these isolated teeth. There is a high risk of high much force to be performed to extract this isolated tooth, so with a risk of trauma and susceptible incidents of oro-antral communication. If it occurs, communication, we should accurately localize the remaining root and support blood clot following extraction with figure 8 suturing to avoid slowing of blood clot. And management of oro-antral communication depend on different factors. Is it acute, meaning communication, or chronic, fistula? Size of communication as assured by radiography. Is it minute, less than 2 millimeters, or average 2 to 4 millimeters, or large, more than 4 millimeters? Is there is infection or not? Whatever the objective of management or treatment is, number one, to stop bleeding if it is acute or current communication. Removal of foreign body, is it the cause of communication, intruded remaining root or implant or even bone fragment? Eradication of infection, as the foreign body intruded is the source of infection. And finally, wound closure, to close the pathway of bacteria from the oral cavity to the sinus. Once the communication happens on the clinical practice, should attempt to primary closure to avoid invasion of bacterial flora, as we said, to the maxillary sinus, causing maxillary sinusitis. However, small oro-antral communication less than 4 millimeters with current healthy sinus, spontaneous healing is followed. However, we should examine the socket carefully and remove any remaining root or fragment visible, and followed by application of topical hemostatic agent to stop bleeding from tearing of minute tearing of sinus membrane. Here is due to the small size of the communication flaps are unnecessary. We just undermine the wound margins and decrease the height of buccal bone to allow approximation of the buccal and palatal mucosa with figure 8 suturing. Here is, as we see, conservative flap elevation followed by reduction of the buccal bone to allow approximation of the buccal mucosa to the palatal mucosa without scoring or advancement, and followed by suturing, figure 8 suturing or interrupted suturing. Following suture is patient instructed to avoid any positive or negative pressure, like sucking through straw, or smoking, or nasal blowing, or avoiding certain sports. Decongestants also are described to decrease edema and enhance ventilation. Antibiotics to avoid infection. After nasal drops, like as decongestants are prescribed. Soft diet on the site of communication. As we said, minute or very small oro-antral communication or fistula heals spontaneously. If less than 2 millimeters, 2 to 4 millimeters can be managed with just reduction in buccal bone and approximation of buccal mucosa to the palatal mucosa and suturing. Very large oro-antral communication, more than 4 millimeters, we can manage the soft tissue defect with flaps. In case of, according to the size of defect, local soft tissue flaps, or distant soft tissue flap. The scope of our lecture will be focusing on the local soft tissue flap or regional flaps, and we're gonna see the difference. In case of patient planning for future implant rehabilitation, or there is insufficient bone for supporting of future denture, patient require hard tissue replacement, otherwise with autograft or different substitute like xenograft, allogeneic graft, synthetic grafts. The different types of local flaps include buccal flaps, palatal flaps, and combined buccal and palatal flaps. And we're gonna discuss one of the regional flaps in the surrounding regions like tongue flaps. Starting with the Rehrman buccal advancement flap. Any type of flap we're gonna discuss should start with removal of the fistulous tract or epithelial tract between the oral and sinus cavity to freshen the wound edges and to remove the diseased or infected tissue. It is the most common technique. It involves a broad-based trapezoidal mucoperiosteal flap with 2 releasing incisions, then followed by scoring or incisions in the periosteum of the buccal flap to allow easy advancement of the flap to cover the defect. Disadvantage of this flap is the raising or advancement of the flap make shallowing of the buccal vestibule and increase discomfort among patients wearing dentures due to frequent dislodgement of denture by movement of the cheek due to lowering or shallowing of vestibule. However, the advantage of this flap is a sufficient blood supply with subsequent high survival rate to low risk of dehiscence and the simplicity and easy to harvest. So as we said, the Rehrman buccal advanced flap is suitable for small and medium-sized defects less than 10 millimeters, can be performed under local or general anesthesia. It's quick, easy, and successful technique with disadvantage, as we said, the reduction of vestibule. It's non-stable by cheek movement, and moreover, fusion of the flap or suture flap with the sinus floor or sinus membrane occurs, leading to difficulty in separation of these 2 layers later on to make grafting for future implant placement. The second buccal flap is a buccal sliding or Maxillary flap. It's most commonly indicated for edentulous patients. Simply, we elevate a trapezoidal flap and slide it anteriorly or posteriorly to cover the defect or oro-antral communication. However, this sliding leaves a denuded area or area of bare bone, but the advantage is it preserves the vestibular depth because we don't advance the mucosa all over the defect. The third buccal flap is the buccal transposition flap. Here, imagine that is the maxillary arch, and this is the site of oro-antral communication. In this case, we elevate a flap that's designed on the attached mucosa parallel to the vestibule, and the flap then rotated 90 degrees to cover the defect on the ridge. However, the disadvantage is that it stores the buccal vestibule and loss of attached keratinized mucosa occurs. The third buccal flap, we have the buccal pad of fat. I confirm again, any buccal flap we perform it after excision of the fistulous tract or diseased epithelium or infected epithelium. Here we make a step incision in the upper vestibule opposite the upper 7. Then we make blunt dissection in upward and backward direction till exposure of the buccal bed of fat. Then gently we advance the buccal bed of fat over the defect and then sutured over the defect. The advantage of this flap is it is highly vascular, provided by the branches of maxillary and facial and superficial temporal arteries. High vascularity promotes faster healing. Moreover, it is abundant tissue and can cover up defects up to 2 centimeters in dimensions, and it's associated with low morbidity and has low effect on the vestibular depth. Here, as we said, after conservative flap elevation, if the buccal bed of fat doesn't appear, a step incision performed in the region of the buccal 7 in the periosteum opposite to it, then we advance the adipose tissue and it can cover the defect and sutured without overlying mucosa with successful results. Moving to the palatal flaps, we begin with the palatal rotational or transposition flap. This flap mainly based on the greater palatine artery. It's a full thickness palatal tissues rotated to a 90 degree to cover the defect after excision of the fistula tract. It's posteriorly based, and during elevation we try to avoid injury to the greater palatine artery because it's the main blood supply of the flap and the main successful point in this flap. Again, due to the heaviness of this flap, it's preferred to perform a preoperative impression to create a palatal stent to support this flap during healing and protect the underlying bare bone till granulation. A beribag, if the stent is not available, a beribag may be placed for a few days to allow for healing. The flap is highly vascularized, as we said, supported by the greater palatine artery, and can cover large defects and can be performed under local or general anesthesia, preferably general anesthesia if feasible. Its advantage, however, it leaves a donor site morbidity or bare bone that it takes long time for healing. The palatal bone takes up to 2 to 3 months for the palatal tissues to granulate and creep to cover the defect or palatal bone. Moreover, as the previous flap, fusion of the periosteum of the rotated flap with the sinus membrane is difficult in dissection to allow for graft placement for implant placement in future. The second palatal flap is the palatal submucosal flap. Here, before rotation of the flap, we dissect the elevated or the palatal mucosa into 2 layers, mucosa and submucosa, in a split thickness fashion, and we rotate the submucosal part to cover the defect and leave the mucosal part to cover the bare bone and to avoid donor side morbidity. However, the risk in this flap is the risk of injury to the greater palatine artery and bleeding from the site, with subsequent compromising the success of this flap. And it's a difficult technique for dissection or skeletonization of the greater palatine artery. For better explanation, this is not a Oro-antral communication, it's a general defect. We elevate the mucosa in a split thickness fashion from the submucosa. Then we elevate the palatal mucosa and rotate it to cover the defect. Then we return the mucosa all over the bone to avoid leaving behind bare bone. The palatal island flap, from the name, we take an island from the palatal mucosa flap, only the anterior part of the palatal mucosal flap, in an island or separated from the palatal mucosa, with attached blood supply of the greater palatine artery. So this flap requires skeletonization or dissection of the greater palatine artery from the posterior part of the flap and leaving it attached only to the anterior island that's finally separated from the remainder of the mucosa, based only on the greater palatine artery attached to it. After dissection and before rotation of the flap overlying the defect, we undermine this palatal mucosa and rotate the flap from below the attached mucosa to protect the artery. In other words, tunneling of the flap below the palatal tissues. The flap here is more flexible in the rotation due to the skeletonization or dissection of the artery from the remainder of the longest part of the flap, and smaller denuded or rare or bare bone is left behind, and so better and faster healing. The palatal submucosal island flap is similar to the palatal mucosal, but except only the anterior island is dissected. This anterior island is dissected in 2 layers, mucosal and submucosal, before separation from the remainder. And we leave the mucosal flap connected with the long part of the flap, and the submucosal part is rotated based or pedicled on the greater palatine artery also to cover the defect. Here in this flap, no denuded donor side or bare bone is left behind. In the bipedicle flap, from the name bipedicle, two pedicles from the buccal side and the palatal side, in which two flaps are raised to cover the defect, either buccal advancement with palatal rotational flap or buccal bed of fat with palatal pedicle flap. Now ending with the local flaps, starting with the regional flaps, we have the buccinator mucosal flap. From the name we have muscle part and mucosal part of the flap. The flap mainly based on the internal maxillary artery, buccal artery and external carotid artery, so it's highly vascular and promote healing with high success rate, meaning that because of its rich blood supply. However, during dissection of the buccal mucosal flap from the cheek or inner side of the cheek, there is a risk of stenosis duct injury if it's not localized first to avoid its injury. Here is marking of the site of mucosal flap harvesting after marking or localization of stenosis duct above. Usually the flap is 2 millimeters below the pathway or the path of the stenosis duct to avoid its injury and salivary gland complication. Here is after elevation of the flap, then rotation to cover a palatal or maxillary communication with the sinus. Another regional flap is the tongue flap. It may be anteriorly based or posteriorly based. However, this flap is rich in blood supply. The flap is raised with the pedicle. The dimensions of the flap, the width should be equal to the size of the defective Oro-antral communication with 20% more in width to compensate for shrinkage of the flap, and the length of the flap should be equal to the length of the defect with 1 centimeter more for smooth rotation of the flap to cover the defect. This flap is performed mainly under general anesthesia to allow, due to the cooperation of the patient with tongue mobility, and it is highly vascularized flap, provide abundant tissue to cover the defect in case of large defects. However, there is difficult feeding following operation because the pedicle of the flap is still attached to the main blood supply at the tongue side. There is a risk also of hematoma formation, sloughing or necrosis of the flap if it's not planned well in the dimensions of the flap or the wider base than the anterior extension of the flap to provide the better blood supply to the flap, with a temporary loss of taste sensation that's recovered following separation of the flap later on, and narrowing of the tongue following suture of the donor side at the tongue side. The flap could be anteriorly or posteriorly based according to the harvest site from the tongue, or taken from the dorsal surface or the lateral side of the tongue. Could be partial thickness, taking mucosa, or full thickness mucosa and muscle. It's indicated in the large Oro-antral fistula or excessive scarring from previous multiple surgeries or failed previous surgeries, and is highly beneficial following irradiation or compromised recipient site, which need a highly vascular flap to cover the defect for better or successful outcome. It have to be performed under general anesthesia, as we said before. Here is example of anteriorly based tongue flap to cover an anterior defect in the maxilla. Another regional flap, the temporalis muscle flap, in case of a very large defect or like following excision of a maxillary tumor leaving large size defect. The flap is harvested, elevated and rotated following its tunneling below the zygomatic arch to cover the defect. Now, what are the factors affecting flap selection or the closure method? Number 1, the defect size. Small size defect versus very large size defect. Previous surgical procedure. Previous surgery means scarring or poor quality surgical bed. Oral hygiene, availability of local tissues, patient preference and surgeon skill. In the current lecture, we discussed local flaps, some of regional flaps, and other flaps are available in case of very large defect or poor quality of surgical beds, like post irradiation, where microvascular flaps are one of the flaps of choice, Prosthetic coverage is also available in case of delayed reconstruction or coverage of the defect. Regarding postoperative care, patients should follow soft food items and drink fluid from the opposite side to avoid trauma to the operated side. Should avoid strenuous physical activities, and surgical stent should be considered to cover the defect, either to support the flap or to cover the oro-antral communication in case of delayed reconstruction. And patients should avoid forceful nasal blowing and keep oral hygiene in optimum conditions. Patient is also instructed to avoid negative pressure inside the mouth and to come back for suture removal within 2 weeks maximum. Suitable antibiotic, analgesic, and nasal decongestants are also prescribed. Now, what are the causes of failure of oro-antral fistula closure? Number one, and the most important, is the incomplete elimination of infected tissues, primarily the fistula tract. Presence or tooth or a root fragment inside the sinus which is left behind undiagnosed before closure of the oro-antral fistula. Placement of soft tissue flap under tension. Any suture should be performed with watertight closure without tension. Inadequate length of flap. We know that flap is subjected to certain percent of shrinkage, so we should consider it in the dimension of the flap to be larger, as we said in the tongue and myomucosa flap, to be larger by percentage to accommodate for shrinkage. Especially in large defects, hematoma might occur with subsequent infection. Inadequate drainage also may result in accumulation of fluids and infection. Moreover, inadequate following the patient to the oral hygiene instructions might result in local infection and dehiscence. Next, what we're gonna do in case of displacement of tooth or root into the maxillary sinus. Initially, the root may be displaced into the sinus or cavity proper, or the cavity itself, or entrapped between the lining and the maxillary bone. Revising the order of teeth approximated to the sinus. The most commonly teeth displayed into the sinus, the third and second premolar teeth or roots. Also, forceful mouth opening under general anesthesia for unconscious patients when using the mouth gag should be considered. Severe maxillofacial injuries or trauma penetrating the sinus or the oral cavity to the sinus, and poor surgical technique. How are we gonna manage? First, by localization of the tooth or root using X-ray, periapical X-ray, or CT, and careful clinical examination can be performed under local or general anesthesia depending on the size of the defect or the type of flap planned. If the remaining root is less than 3 millimeters and uninfected with history of no infection, nothing may be attempted to avoid more trauma to the patient or widening of the communication. If it's large, more than 3 millimeters, or infected or with history of infection, or infection is evident with clinical examination, we should localize it and retrieve it with either endoscopic examination or via Caldo-Lac operation, as we discussed before, to remove this foreign body or remaining root. And finally, after removal of the source of infection, we close the oro-antral communication or fistula. Short notes on pathological sinus involvement other than we said. It might include cysts or tumors affecting maxillary sinus. Other than pathology, there is some types of fracture that might affect or involve the maxillary sinus, certain surgeries involving the maxillary sinus. From the cysts affecting maxillary sinus, they are usually asymptomatic and discovered by routine examination, like routine panoramic X-ray. They are classified either cysts occurring within the sinus, like benign mucosal cysts or mucoceles arising from the Schneiderian membrane, or cysts start outside the sinus and encroach on the maxillary sinus, like starting in the oral cavity or the periapical region and expand to encroach on the maxillary sinus, like periodontal cysts, dentigerous cysts, and odontogenic keratocysts. Here we see an example of entrancing cysts starting within the sinus or arising from the maxillary sinus lining, and it's large enough to expand to cause deviation of the nasal septum. Here one of the extrinsic cysts or the radicular cyst. It develops outside the sinus within the alveolar process but encroaches on the sinus membrane. It's characterized by thin sclerotic border that delineates the cyst from the rest of the sinus. May occupy the entire sinus or just encroaching on the sinus, causing communication following dental extraction with attached lesion. Odontogenic keratocyst is now defined or named like keratocystic odontogenic tumor, considered as tumor, not true cyst. It's usually associated with an unerupted tooth. It's one of the benign tumors. Dentigerous cyst also is associated with the crown of unerupted tooth, filling the whole cavity of the sinus. Here we can see the unerupted tooth and the delineated or attached cyst. It's one of the characteristics of dentigerous cyst is association with the crown of unerupted tooth. Another cyst that commonly follows surgical procedures involving the maxillary sinus is called surgical ciliated cyst. It's a locally aggressive lesion that appears as a delayed complication of surgery, like orthodontic surgery or caldo-lac radical antrostomy. Here is namely the most common malignant tumors affecting or encroaching on the maxillary sinus, either originating from within the sinus lining itself, from the lining, or from the oral cavity encroaching on the maxillary sinus. The fractures involving the maxillary sinus, starting with zygomatic maxillary complex fracture, ZMC fracture, and Lefort 1 and Lefort 2 fracture. And anatomic wise, never say that Lefort 3 fracture might affect the maxillary sinus. Here is also orbital floor fracture encroaching on the maxillary sinus with trapdoor fashion, ZMC fracture. Here is tuberosity fracture. Surgeries like orthodontic surgeries include also Lefort 1 osteotomy, which encroach on the maxillary sinus, and open reduction internal fixation in case of trauma might affect or cause injury of Schneiderian membrane with, as we said before, delayed surgical cyst development. Regarding sinus floor augmentation, it's a surgical technique that's used for increasing the bone volume in the deficient posterior maxilla or atrophic maxilla, also called maxillary subantral augmentation or internal augmentation or inlay grafting. However, this procedure is contraindicated in case of acute sinus infection, excessive interosseous space where an inlay graft is suitable in such case, uncontrolled metabolic disorder like uncontrolled diabetes mellitus, heavy smokers, and presence of septic focus or root fragment within the sinus. Based on the surgical approach for sinus augmentation, there is a lateral approach, as we saw before, and crystal approach. The grafting material following the lateral window or crystal approach might include autogenous bone grafts or its alternatives, and membrane for guided bone regeneration. And implant installation protocol might be simultaneous with grafting in case of initial sufficient bone not less than 4 mm to guarantee primary stability, or delayed in case of bone height, residual bone height less than 4 mm. In such case, a delayed implantation following grafting is recommended. Also, the implants after its installation might be submerged or exposed to the oral cavity with healing collar attached. Here we see the lateral window approach, or called lateral antrostomy, followed by grafting following elevation of the sinus membrane. And here is the crystal approach, where a crystal approach followed by suitable sequential osteotomes used to elevate the sinus membrane, then grafting through the crystal approach, still raising the membrane, followed by implant installation. Here's again the windows delineated on the lateral side of maxilla, the bone window which was delineated with round bearings elevated gently with the attached sinus membrane in a trapdoor fashion. This is followed by an implant installation case. We said sufficient residual bone, more than 4 millimeters, and this procedure may or may not associated with grafting. With grafting or without grafting, what's called tenting technique, where the sinus membrane is elevated or tented over the implants, and this space between the sinus membrane and the alveolar process is later on filled with bone by the negative tension or tension induced by elevation of the sinus membrane away from the alveolar process. There are different techniques for the crystal sinus approach, either osteotome sinus floor elevation or osteotome augmented sinus floor augmentation, or balloon, which is inserted within the socket and inflated gradually with saline to separate the sinus membrane away from the alveolar process, followed by implant installation. There are different grafting material in case of two-stage sinus augmentation, where insufficient bone less than 4 millimeters is available for simultaneous implantation. So in the two-stage surgery, the autograft are the gold standard for its osteogenic, osteoinductive, and osteoconductive potential. Allograft is alternative, and xenograft or alloblast to avoid donor site morbidity. More recently, tissue engineering grafts and before it tenting technique is, we said, in case of sufficient bone that guarantee primary stability for implant to allow the membrane to be tented over the implant. Thank you.